ultrasound-guided carpal tunnel release in the presence of a reversed Palmaris longus muscle belly. Conflicts of interest. I'm a stockholder with Sonix Health. I am a co-editor of a textbook on ultrasound and a lecturer for expert education. Ultrasound-guided carpal tunnel release is normally a simple procedure in experienced hands. This video shows a structure which might at first be considered a contraindication. The reverse palmaris longus is called that because its muscle belly is distal rather than proximal. Radially, it may be attached to the side of the flexor carpi radialis tendon. The muscle ends in the deep fascia of the distal forearm and in the transverse carpal ligament. In carpal tunnel release, the usual safe zone is the area between the radial side of the ulnar artery and the ulnar side of the median nerve. In this view that we have here, the zone itself is wide, but the entry is compromised by the overlying palmaris longus muscle. Note in this area that the honeycomb pattern of the median nerve is normal. As we approach the transverse carpal ligament and the entrance to the canal, the muscle tapers, but the nerve enlarges. Note that the loss of the honeycomb pattern in the nerve as it approaches the entrance to the canal. If we decrease the pressure on the probe, the ulnar veins dilate and may appear to be a compromise of the safe zone. We start our hydrodissection a little bit more proximal so that we can hydrodissect between the nerve and artery and allow the palmaris longus muscle to drift a little bit radially. Note that we're not too far proximal as the lunate is still in the frame. A full hydrodissection creates a larger safe zone and a working zone. Distal to this area, everything appears to be normal for an ultrasound-guided carpal tunnel release. Here we see the lidocaine dissecting underneath the transverse carpal ligament, which is seen in cross-section between the arrows. Distal is on the left and proximal is on the right. Here in the short axis view, we are making our incision midway between nerve and artery. And then we pass our uterine dilator in the usual fashion, and this appears to be a normal ultrasound-guided carpal tunnel release. Adjacent to the dilator, we can see the median nerve in long axis, again, as one would see in a normal ultrasound-guided carpal tunnel release. Here in short axis, we see the dilator between vessel and nerve, and distally we can see it again. Distally we're actually a little beyond the canal, and we see the median nerve breaking up into its terminal branches on the left and the ulnar artery and nerve just to the right of the dilator. We then place the cutting device in the usual fashion. We want it to be tightly applied to the overlying ligament and the blade to be at about the distal edge of the ligament. Here is a view of the more volar surface of the cutting portion of the device as it's progressing from distal to proximal. And here we are checking the release with a dilator. In summary, this case shows how some apparent blocks to ultrasound-guided surgery may be moved with hydrodissection. Thank you for your attention.